So it's a couple of minutes past 10 o'clock. I think what we probably should do is make a start, and I'm sure there will be a few more people joining as we go through this morning's session, and that's fine. Like I said, we are delighted to welcome you to our event this morning, which is a National Coroners Court. My name's Ellen Buckley, and I'm one of the tissue viability nurse advisors working with Coloplast, and I'm delighted to be joined this morning by my two very good looking colleagues, Charlie Pick and Sam Wharton, who are also tissue viability nurse advisors working with Coloplast. And we, between the three of us, have a wealth of experience within tissue viability. I'm really excited for you to join us today to join an event which we hope and we are sure that you will get a lot out of. Our coroners courts that we run both virtually and face-to-face are very well attended, and we always get extremely good feedback. So I'm sure that you will get a lot out of it. So the way this morning's session is going to run is that we will start off by doing a session around the importance of your documentation. So it's worth saying that it would be extremely unlikely that any of you would be called to give evidence in a coroner's court. I certainly have never been called to give evidence in a coroner's court. And so I suppose the way that we plan this session is to sort of reinforce how your documentation can support you if you were ever to be called to give evidence in a coroner's court, but also with internal investigations as well. So your documentation, it's not something that's optional. It's absolutely key and fundamental into the evidence that you have for the care that you have delivered and the decisions that you make. So that's what the first part of the session will be about. And then we're going to move on to how we can simplify wound healing and help make lives easier for our patients, and how we can make lives easier for ourselves as clinicians, and the three-step approach that Coloplast are talking about at the moment, which will facilitate making lives easier. And then for the latter part of the morning, Charlie is going to present the Coroners Court session. So get your popcorn at the ready. It's always a really a good event, and please be as interactive as possible with the Coroners Court. We love to hear your points, your questions, your thoughts about the videos that you see during the Coroners Court session. Both myself, Charlie and Sam will be having discussions after each video. There are 5 videos that we have to show you with discussion points in between each video, just so that we can hear your thoughts about what you feel has happened. Would that have happened now? Would that have happened in your local area? Any lessons that we can learn from these events? So without further ado, I will share my screen and we'll get going with the documentation part of our presentation this morning. So this session is around meeting the coroner in court. But as I said, it's really important that we think about how our documentation can support us in evidencing the care that we give to patients and evidencing the decisions that we make in a patient's care. But we're here to talk about pressure ulcers this morning. That's what this Coroners Court session is about. And it's important to remind ourselves what it is that we're talking about, what actually is a pressure ulcer. And we have a definition that we work to when we talk about pressure ulcers. So we know that pressure ulcer is a local damage to the skin and the underlying soft tissue. It's usually over a bony prominence or related to a medical or other device due to unrelieved pressure. And pressure ulcers can present in different ways, which can make the classification, the categorization, the assessment of pressure ulcers quite tricky sometimes and quite complex. But essentially, a pressure ulcer can present as either intact skin or as an open wound. They can often be painful, and it's often said that pain is actually one of the earliest indicators of a patient developing a pressure ulcer or pressure injury. Not all of our patients can articulate to us or tell us that one of their at-risk areas is painful. So that's worth bearing in mind as well. Pressure ulcers occur often as a result of intense and or prolonged pressure, occur as a result of pressure in combination with shear. And I think it's important to remind ourselves what it is that we're talking about, what it actually is a pressure ulcer, what does it mean to us, and how do we see this kind of wound etiology presenting in the patients that we assess and manage. Pressure ulcers continue to have a huge impact within the United Kingdom. Over 1,300 new pressure ulcers are reported every month, affecting over 200,000 people annually within the UK. They continue to be the single most costly chronic wounds to the NHS, and they can account for up to 4% of the UK healthcare budget, or £2.1 billion a year. And when we think about how many of these pressure ulcers were preventable, how many of these pressure ulcers possibly didn't need to happen if the appropriate action was taken to put measures in place to mitigate the risk of these patients, then possibly we are spending a lot more money than we actually need to spend on managing these pressure ulcers. So pressure ulcers in older patients, we know, are associated with a 5-fold increase in mortality. In hospital mortality in this group is around 25 to 33%. So a huge, massive impact that pressure ulcers have within the patients that we see. We have pressure ulcer clinical recommendations and a clinical pathway recently published by the National Wound Care Strategy Programme. And if you haven't had the opportunity to go on the National Wound Care Strategy Programme website, I would encourage you to do so, because you will be able to find a link to the new recommendations on their website. So we now, and have done for some time, but categorise pressure ulcers using categories 1 to 4. We are told that where the skin is broken but the wound bed is not visible due to slough or necrosis, we would normally or have formally referred to these as unstageable pressure ulcers, but we're now recommended by the National Wound Care Strategy Programme that these should initially be recorded as a category 3, but immediately recategorised and recorded if debridement reveals that that pressure ulcer was actually a category 4 pressure ulcer, because some underlying structures like bone, tendon, muscle fascia have been revealed once that debridement has taken place. And something else that's quite new is that deep tissue injury, or DTI, should not be recorded as pressure ulcers unless they result in broken skin. Now, there will be, I would imagine, a phased implementation of these new recommendations within organisations to bring in line what the National Wound Care Strategy Programme is recommending we do in terms of categorisation and in terms of incident reporting in relation to pressure ulcers. But it's worth bearing in mind, if this isn't the case currently within your own organisation, obviously refer to your own policies and guidelines about reporting pressure ulcers, but you might see this emerging within your own organisations as we move forward. So just a reminder, we have 4 categories of pressure ulcers: Cat 1, Cat 2, Cat 3 and Cat 4. And the unstageable and deep tissue injury pressure ulcers, we are now having changing recommendations to advise us about how we should deal and manage this previously reportable category of injury. So this is an interesting slide, and it's basically in reference to litigation that we have statistics on in relation to hospital-acquired pressure ulcers in the emergency department. So there is an agency called NHS Resolution, which is a part of the Department of Health. And the NHS Resolution Agency provides indemnity to the NHS for the risks involved in delivering different healthcare services. So in relation to the hospital-acquired pressure ulcers in emergency departments, for example, in 2021, there was a total of £2.4 billion in payment attributed to this category, or this etiology of wound that occurred within the emergency department. And just taking that into context, the total NHS budget was, £199 billion. So quite a large proportion of that total NHS budget was attributed to payments made out because of hospital-acquired pressure ulcers within a very specific area or department within the NHS. Between 2010 and 2011 and 2019 and 2020, NHS Resolution Agency were notified of 1,781 claims relating to hospital-acquired pressure ulcers. And NHS Resolution settled around 15 hospital-acquired pressure ulcers at a cost of almost £300,000. So I would ask you to reflect on why you feel, given the amount of hospital-acquired pressure ulcers within this department were reported, and how many of those claims were settled out of court. Could there be anything that we see within this morning's session which could be a reason why most of these cases were settled out of court and not taken to court for the NHS to be able to defend within that particular claim or case? Just have a think about that as we move through this morning's session. There are often case studies that are published within different journals and different publications. And this is just one example of an illustrative case study around a patient who developed a pressure ulcer. So the patient was a resident in a care home. They attended the emergency department after a fall. They had a risk assessment carried out. In this case, it was a Waterloo risk assessment. And as part of that risk assessment, the patient was identified at being high risk of developing a pressure ulcer. Within the ED, they were placed on a Biflex mattress, so specialist equipment to help prevent pressure ulcers while they were in that department. But they ended up being in that emergency department for nearly 17 hours. And that had significant impact on this particular patient, despite the fact that they were placed on a specialist mattress, and despite the fact that they had a pressure ulcer risk assessment tool completed as part of their care while they were in the emergency department. So the case study highlights to us that in this particular case, there was a failure in care. So there were care lapses for this particular patient. So despite the fact the patient had a risk assessment completed, there was a failure to record a documented or to document a skin inspection of this patient who, as part of the risk assessment, had been identified as being high risk. That skin assessment wasn't recorded within the patient records on a body map. And that was highlighted here as being a significant event in this patient's journey. There were gaps identified within the nursing documentation. So again, let's have a think about the quality of our documentation when we are doing wound assessments, pressure ulcer assessments, holistic assessments with the patients that we come into contact with. Are there any gaps that we could potentially identify and improve upon within our documentation? Within this case, we're also told that there was a failure to perform regular nutrition reviews whilst this patient was in the emergency department. And I suppose when I've read this case study, I've reflected myself, well, what does a nutritional review mean while the patient is in, the emergency department? And I feel, for me, in this case, it was possibly that when the patient received, food and drink, it possibly wasn't documented or recorded within an intake sheet or record during the time that this patient was in the emergency department, and perhaps that is what this is referring to. There was a failure to perform 2-hourly care and comfort rounds within the emergency department. Does that mean that this didn't happen for this patient? Possibly it didn't happen, but possibly it did happen. But there was a failure to record the care that was given for this patient while they were in the ED department. And there was a lack of record that this patient was repositioned and at an appropriate frequency while they were on that trolley in the emergency department. Again, does this mean that that care wasn't given, or does it mean that it just wasn't recorded within that patient's record? We know that there is a massive impact also of pressure ulcers for the patient themselves. We know that pressure ulcers can lead to, quite severe disability, such as amputation for patients. Sometimes a patient would require an extended hospital stay, so an increased inpatient stay if a patient develops a pressure ulcer, or there are complications secondary to that pressure ulcer while the patient is in for some other reason. And perhaps you might see sort of clues about that as we go through the coroner's court session later on this morning. We know that pressure ulcers, there is a high incidence of patients developing an infection in their pressure ulcer. And when we talk about pressure ulcers that are category 4 pressure ulcers, for example, where there is underlying structures exposed, there is a higher incidence of osteomyelitis, so infection within that bone. And these are all secondary complications when a patient develops a pressure ulcer, which could have a huge impact on a patient's quality of life. Pressure ulcers can be life-threatening, as we will see during the Coroners Court section of this morning's session. And we need to really bear that in mind and sort of, put it back into context. For lots of patients, there are potential care lapses where there are missed opportunities to prevent this pressure ulcer from occurring for particular patients, and perhaps patients could potentially end up in this life-threatening situation where potentially they didn't need to. We need to always bear this in mind when we're looking through or going through this morning's session. Now, this might be new to some people on the call today. It might be something that has already been adopted within your local area. So there is now a patient safety incident reporting framework, and this just isn't in relation to pressure ulcers themselves as an etiology of wounds, but any kind of patient safety incident that's reported on a clinical reporting system. So whichever clinical incident reporting system that you use within your local area, it might be Datix, it might be Ulysses. I'm sure you'll be familiar with whichever system that you use to report patient safety incidents. So when you identify that a patient has a pressure ulcer, you would report it on your whichever clinical incident reporting system you use locally. And then that incident is often verified by whichever clinician is deemed appropriately trained locally to verify that actually, yes, this is the incident that you reported it as being. So in terms of pressure ulcers, there might be a tissue viability nurse, for example, or a ward manager or a district nurse team leader who comes to see the patient and says, yes, this actually is a category 2 pressure ulcer. This is a category 3 or 4 pressure ulcer. So that would then be verified on the patient safety incident reporting framework to say, yes, this is what it was initially thought to be. And then we need to think about how we engage with those involved within that patient safety incident. So in terms of a pressure ulcer, how do we engage with the patient themselves about what has happened during their journey within our organisation, and possibly relatives, parents, carers. How do we engage compassionately around the incident that unfortunately has happened to this particular patient? We need to think about how we have open communication around patient safety incidents. That might be a sort of duty of candour, for example, if that's a term that you're familiar with. And we'll delve into duty of candour in a bit more detail in a few slides on. But we need to be very open in how we communicate what has happened. What has happened? How do we plan to deal with it? How do we look into how this has happened? And what measures are we putting in place to limit any future harm that possibly could come to this patient. We then use a variety of system-based approaches to learn. So how do we learn from patient safety incidences? In pressure ulcers, we will often have internal investigations and come up with root causes, for example, about what happened in this particular case. Was there a service delivery issue? Were there lapses in individual direct care to that patient? And what can we do to improve on that in the future? How do we learn from the things that happen in relation to the incidents that happen to our patients? And then we need to be very considered and very proportionate in our response to these incidences that happen. How do we share those lessons across the organisation? How do we make sure that our responses are proportionate to the incident that happened? So, for example, if a patient's mattress perhaps was ill-ordered but not delivered in time, or it was the wrong piece of equipment that was delivered to that patient, what is our response as an organisation to that? So that will vary, obviously, depending on the incidents or the themes that arise as part of that incident, and how we respond to that will obviously vary locally within each organisation. So we also need to be very supportive in our oversight, focused on making sure that we strengthen our response system, and how we improve the services that we deliver and the care that we deliver to patients. And then obviously we need to have a policy and plan in place within our organisations as to how we respond to these patient safety incidences that happened. So again, how do we share best practice? And how do we learn from lessons from incidents that happen, in particular patient safety cases? And sometimes after an internal investigation, there are other things that will happen as a consequence of that patient safety incident. So sometimes there are disciplinary hearings or capability hearings internally within our organisations, and actions that will happen as a result of that particular hearing, whether that be action plans that are put in place for a particular service or individual. Sometimes there does need to be a coroner's inquest, unfortunately, about a patient safety incident. Sometimes there are criminal proceedings that take place. Sometimes there might be a public inquiry. Sometimes clinicians are referred to their professional body for a fitness to practice hearing. So these are all possible consequences. Obviously, they're not going to all happen for all cases, but they are just possible consequences and something that you might hear or see happening as a result of a patient safety incident or investigation within your local organisation. As professionals, we are obviously personally accountable for the actions and omissions in our practice. As nurses, as clinicians, whether we be nurses or allied health professionals, we make judgments in a huge variety of circumstances. We use our own professional knowledge and skill to make a decision based on what is current evidence for best practice and is acting in the person's best interests. We need to be able to justify the decisions that we make. And this is where our documentation should absolutely support our decision that we make. Um, you know, Coroner's inquests, for example, don't always happen, immediately after that patient's episode of care. Sometimes they happen months after that patient safety incident, where unfortunately that patient came by their death. And if you are called to give evidence within a coroner's court, or even within an internal investigation, you need to rely on your documentation to support the decisions that you make as part of that patient journey. Why did you put that dressing on that patient's wound? Why did you not inspect that at-risk area on that patient's heel that particular day? What was the justification for that care having been given or that care having not been given for that particular patient? I spoke before about duty of candour, and this is about being open. So it's absolutely vital that healthcare professionals understand what it is, what their responsibility is in being open and honest with the people who use our services, with their employers and to the Nursing and Midwifery Council. And I feel so duty of candour was implemented when I was a tissue viability nurse in Liverpool community. And to be fair, there was a lot of anxiety created among nurses within the organisation around the implementation of duty of candour, because it's essentially about saying sorry. So we are communicating with the patient's family, with the patient themselves, saying, look, this incident has happened. We are sorry that it's happened. And I suppose there was a perception for some healthcare professionals that saying sorry is an admission of guilt, when in actual fact, it's not an admission of guilt. At the end of the day, we are sorry as a body of healthcare professionals, as an organisation, that this patient safety incident has happened. And we are being open with you to say, yes, this has happened, and we will be looking into how this has happened, and we will continue to communicate with you around this incident. But this piece of documentation here, this guidance, is available on the NMC website if anybody feels the need that they want to go and have a little bit more of a look, an in-depth look into what duty of candour means. So in terms of the coroner and a coroner's court, should you unfortunately ever be called to give evidence in a coroner's court, I think also it's often perceived as quite a negative experience, and that's completely understandable why you would feel extremely nervous about having to go and give evidence in a coroner's inquest. However, it's also an opportunity to showcase really good practice, gold standard care. And this is where your documentation will support you in being able to demonstrate, do you know what? This happened, but the care that we gave to this particular patient was exemplary. And I know of, several examples of where this was the case. A tissue viability nurse that was called to give evidence in a coroner's inquest, but actually, they were contacted pre-inquest to say, actually, we don't need you to attend because your documentation absolutely supports the care that was given, and we can see what care was given and the reasons why that care was given for this particular patient. So you don't actually need to come and attend this inquest because your documentation says all of the questions and answers all of the questions that the coroner would ask. But absolutely, sometimes, we do need to go and attend a coroner's inquest to provide evidence about the care that was given in a particular case. But the coroner's jurisdiction is limited to determining who the deceased person was, how, when, and where they came by their death. And it's obviously usually, it's obviously obvious. It's obvious to the coroner it's normally known who that deceased person was. It's normally known when they came by their death and where they came by their death. What the coroner's jurisdiction is to understand how that person came by their death. So when the death is suspected to have either been sudden with an unknown cause, violent or unnatural, it's the coroner who decides whether to hold a post-mortem, firstly, and if necessary, whether an inquest needs to be held in a particular case, because actually how they came by their death is unclear sometimes. So there are two different types of inquest, and sometimes there is a pre-inquest hearing. So if a full coroner's inquest can't be held within days of the deceased person's death, the coroner will open the inquest at a short hearing, which is called a PIR, or a pre-inquest review hearing. And the coroner will, at this hearing, decide how long the inquest is likely to last and whether a jury will or will not be needed. It's not usual for a jury to be called in a coroner's inquest, but it does sometimes happen, depending on what evidence is presented to the coroner during the inquest. And then the coroner's inquest itself is a legal inquiry into the death when, as I said before, the cause is either unknown, it's violent, or it's unnatural. Coroner's inquest is held in public, so anybody is able to attend a coroner's inquest. You will find information about the coroner's inquests that are taking place within your local area if you visit your local city council website, where there will be a link to coroner's inquests. As I said, they're all held in public, so anybody's able to attend. And the only reason, the only inquest that you would not be able to attend is if it's a child, or is it if this inquest is in the matter of public public threat, if you like. So if it's in a matter of national security, I should say, where you wouldn't be able to attend that inquest. And as I said before, the inquest is normally held without a jury, depending on what evidence is presented during that inquest itself. So should you be called to give evidence at a coroner's inquest, your duty is to the court and the coroner themselves, and they will expect you to answer their questions as accurately as possible under oath. It's not the coroner's role to apportion blame. It's simply a fact-finding mission. And that's important to reiterate, because I suppose in that environment, in that situation, you can feel quite vulnerable, as if you're being, quizzed into, to things that possibly, didn't go to plan, or where things might not have gone to plan for a particular patient, and you feel like you're under cross-examination, if you like. But it's not a cross-examination. It's simply a fact-finding mission. And this is where your records are absolutely invaluable to support you in being able to answer those coroner's questions. So if your records are not full and complete, you may struggle to answer some of the questions that the coroner asks to be able to provide the appropriate evidence in this particular inquest. You should only state facts and not speculate when you're given evidence. So you can't just presume or assume that a certain aspect of care that was given, if it isn't documented within that patient's clinical record, then that care didn't happen. Whether you feel it was given or wasn't given, if it's not written down, it wasn't done. And that's really key. And we are told this when we talk about and have our mandatory training about documentation. We are told this over and over again. If it's not written down, it wasn't done. This is where your records absolutely support you in providing the evidence and to the decisions that were made in a particular patient's care. And if you don't know the answer to a question, it's okay to say that you don't know. And you should also only answer questions that are pertinent to your particular speciality. So an example of that I would give is I'm a tissue viability nurse, and if I was there to provide evidence on a tissue viability aspect of care that was given, and the coroner chooses to ask me a question about the patient's chronic heart condition, for example, it would be okay for me to say, I'm sorry, I can't answer that question because that's not my area of specialty. My area is tissue viability, and this is what I'm here to answer questions about. But at the end of the day, it's okay to say that you don't know the answer to a question if you don't know. That's always better than speculating about what did or didn't happen. So these are the current findings of fact, conclusions or verdicts that the coroner would come to at the end of an inquest. So we have 6 conclusions that the coroner is able to choose from. The coroner might find that the patient died through natural causes, so a normal development of a natural illness which wasn't significantly contributed to by human intervention. So death by natural causes. I'm sure we're all familiar with that terminology. They might also come to the conclusion that the deceased person came to their death by accidental death or death by misadventure. So this is where the cause of death was unnatural, but it wasn't unlawful, and the deceased person has taken a deliberate action themselves that has resulted to their death. So I do actually have a personal example of that. I had an aunt who was very elderly, and unfortunately she stepped into the road and she was knocked over by a man driving a van, and he wasn't speeding. She took a deliberate act to step into that road because she didn't hear that that van was coming down the road towards her. And unfortunately, that deliberate action resulted in her death. So in terms of her coroner's inquest, the conclusion that the coroner came to was that she died through accidental death. Unlawful killing, so through murder, through manslaughter, through infanticide, or a serious driving offence. So another conclusion or verdict that the coroner might come to at the end of the coroner's inquest. Suicide, where the deceased person voluntarily acted to end their life in a conscious way. It might be a verdict or conclusion of neglect. So there was a gross failure to provide the deceased person with basic need. And finally, there might be a conclusion of a narrative verdict or a narrative conclusion. And this is where the coroner sets out the circumstances of the death of the deceased person in a very detailed way, based on the evidence that is heard during the inquest. So this is often the case where there are several different aspects of the care that was provided, or several different things happened which led up to this person dying. And this is often the case when a narrative verdict is come to or decided upon by the coroner. And in addition to the conclusion or verdict, the coroner might also decide that he or she would want to impose a Regulation 28. So a Regulation 28 is where there might be a future prevention of future death report. And this happens when the coroner has heard all of the evidence, but feels that there are actions that need to be taken to prevent future avoidable deaths. This might be imposed on a particular service or a particular organisation or authority. So the report is sent to that particular person or authority, and that person would be the person or authority that has the power to make the changes that are suggested to prevent future death within that particular organisation. The authority that the Regulation 28 is imposed upon, they have 56 days to show how they have either made changes according to the coroner's recommendations or how they intend to make those changes moving forward. And again, I would ask you to think as we move through this morning's session about the Regulation 28, and as you watch the videos of the Coroner's Court, think about to yourself whether you feel a coroner or an organisation would want a Regulation 28 enforced or imposed upon them. What does that look like for an organisation? And bear in mind that all of the verdicts or conclusions that are come to following the coroner's inquest are in the public domain. So the public have access to everything that happens as a result of a coroner's inquest. So please bear that in mind as we move through this morning's session a little bit further. Again, I'll keep coming back to record keeping. So our record keeping, our documentation is an integral part of our NMC code, and also of the professional body that allied health professionals register with as part of their practice. It is absolutely essential to the provision of safe and effective care. It supports communication between different organisations and between different services. Even within the same service, your documentation will support the care that is given. So if I'm a nurse and I'm coming to review or reevaluate a patient's pressure ulcer, the documentation of the nurse who saw that patient before I did or did that previous evaluation is going to help support my decision about whether that wound is improving or deteriorating or is static. And without all of that information being afforded to me, it makes it much more difficult for me to make the decision about whether about what I can do to move this patient's care forward. It's not an optional extra. It's something that is fundamental and will support the decisions that we make. And it's worth bearing in mind that our patient records are not just the electronic records that we type on. They are not just our paper documents that we might write on. Our records include anything that makes reference to the care of that patient and can be called in terms of a coroner's inquest and used as evidence as part of a serious incident investigation, whether that be an internal investigation or whether that be an external coroner's inquest. So any kind of record that makes reference to that patient could be called as part of evidence. And these are just some examples of everything that forms a patient's record. So it could be emails that make reference to a patient. It could be our paper documentation in terms of patient health records. It could be electronic patient records, our care plans, our risk assessments that we do, x-rays, any telephone conversations that are had where you might have a telephone message book, or you might make a note on a post-it note, for example, about a patient's taking a message about a patient. That all forms part of that patient's record and could be called as part of evidence into the care that was given for that particular patient. As I said before, if it's not written down, it didn't happen. We need to pay careful attention, and often is the case, as I'm sure you'll see in the videos that you'll watch later on in this morning's session, the records can let us down, and possibly we feel that we don't have time. We're always so rushed. I didn't have time to write it there and then because I was too busy. Not being busy, or being too busy, I should say, not having the capacity or the resource to have the time to be able to write the care that was given for that patient isn't an excuse, and it would not stand up in terms of an investigation. If there are issues within your capacity or your ability to complete your patient records, then that needs to be escalated through your line manager and whichever clinical incident reporting system that you have available to you to escalate. Hold on, I'm really busy here and I'm struggling to find the time to record all of the care that I gave for this particular patient. So some common problems that you might find within patient records, and certainly I'm sure my tissue viability nurse advisor colleagues will agree. We have done lots of clinical investigations internally into where there have been care lapses, into pressure ulcers probably most commonly, but other aspects of tissue viability too. And documentation without fail in every investigation I've done, it's the documentation that is a common theme, and it's where our evidence into the care that was given to that patient has failed. So often there might be an absence of clarity. So you might be talking about a patient with a pressure ulcer on their buttock, for example. So whereabouts in the buttock? Where do you mean? Do you mean an ischial tuberosity? Do you mean a sacrum? Do you mean the coccyx? Do you mean a hip? Where is it that you mean? So buttock is a very vague and it's not clear as to the area of anatomy on a patient's bottom where they could potentially develop a pressure ulcer. So there needs to be real clarity in what it is that you're talking about. So if you record, if you identify a problem with a patient, sometimes there is a lack of recording of the action that was taken. So if you identify that you are seeing signs and symptoms of infection, you need to say what action you took for that patient because of the problem that you identified. If you identified that a patient is at high risk of developing a pressure ulcer, what action did you take because you identified that problem to mitigate the risk for that patient developing that pressure ulcer? Failure to escalate. Again, wound infection. If you identify a patient's got a wound infection, who did you tell? Who did you notify? Did you record that within the records? Some missing information. So I think wound assessment charts are a really good example of this, where perhaps wound dimensions are not recorded, tissue types are not recorded, the category of pressure ulcer is a bit vague, and just missing information within the record. Inaccurate wound measurements. We need to be really clear about where these measurements were taken, and make sure that they are documented really accurately within the patient's clinical record. Again, some things that people record within the patient's record can often be very vague. So in terms of exudate, for example, the wound was leaking plus, the wound was leaking plus plus. So what does that mean? It's so subjective. And what is leaking plus to me might be leaking plus plus to somebody else. So we really need to have a level of objectivity when we're recording wound exudate, for example. Mattress ordered. That's another thing that is not sort of very clear. So what mattress ordered? When was it ordered? When is the expected delivery? Who is there? Who is going to be there to make sure that mattress is put in place and is being used appropriately on that particular patient? Patient repositioned. So repositioned how? On the left side, on the right side, using what equipment? What was their skin inspection like? Were there any causes for concern during that repositioning episode for that particular patient? All just common things that I certainly have come into contact with when I've been doing investigations. But sometimes just a tiny bit more information to add into that record can give a huge amount more clarity to what it is that actually happened for that patient. So again, I'm not going to go through every single one of these, but just to pick out one or two. Turn 3 hourly. So why are you turning the patient 3 hourly? Well, my rationale for turning the patient 3 hourly and not 4 hourly or 2 hourly is because so I'm turning 3 hourly and not 2 hourly because when I turn the patient 2 hourly, their skin is fine. They don't need 2 hourly repositioning. I'm going to turn the patient 3 hourly because that's fine. And I'm going to continue to do those skin inspections and record them within the patient's records. Care given, concerns discussed with and escalated to. So sometimes it's just a few more words can really help support the evidence for the decisions that you make, having done a reassessment on that particular patient. I'm going to stop sharing my screen slightly. Is there any comments come in, Sam, Charlie?
So we've had quite a few comments just about that documentation, and just I think there's a bit of I think actually attending this session's just reiterated to people the need to record things, and there's some chat going on about potentially you could be called up to years until you get called to go. So you really need to be able to document it, because if you haven't got that written, you're not going to remember what happened months, weeks, years ago.
And absolutely. And the tools that we have available to us in terms of wound assessment, for example, or pressure ulcer risk assessment are nationally recognised as best practice and best tools that are available to do that. So we should use the tools that are available to us in terms of our wound assessment, in terms of our pressure ulcer risk assessment, because if we use the tools effectively, they will absolutely support the practice that we give and evidence the care that we give. Would you agree?
Yeah, absolutely. There's also just talking about patients, their concordance, and how to ensure patients are sort of concordant with treatment options. And it was we were just sort of saying, you need to make sure that patient's fully informed, has all the understanding in the material that they understand, and has the capacity to make that decision, because at the end of the day, patients are allowed to make unwise decisions as long as we as clinicians have given them all the options and they understand. And it's not once you say no, you don't want that piece of equipment, for example, you can still revisit that conversation, and you can still reiterate
I think that's a really key point, Sam. So a patient, you know, once we've established that they have, you know, a full mental capacity to understand the risks, benefits, and alternatives to the element of care that we are suggesting, they also and they decline that, and we've, you know, they are aware of all the risks, but still they choose to make that unwise decision. That's fine, and it's okay. I think sometimes we do run the risk of sort of bullying patients sometimes because we are so frightened of them developing a pressure ulcer. So I think that's something to bear in mind. But also the patient needs to have the continued opportunity to consent to that aspect of care. So as you said, just revisiting that and reiterating those risks, benefits, and alternatives, you know, for whichever frequency is appropriate for that patient. Charlie, did you have any thoughts to add?
No, there's just a couple of questions around pressure ulcer categorisation and if there's any documentation regarding this. So it's just to point you in the direction of their National Wound Care Strategy Programme. They've just released the pressure ulcer guidance, and the categories have changed slightly, as Ellen discussed earlier. So if you take a look at the National Wound Care Strategy Programme website, the guidance for the categorisation of pressure ulcers is on there for you.
Yeah, absolutely. And, you know, I mean, I'm sure, you know, both Sam and Charlie and I, we go on that website quite frequently, and it's a huge, you know, source of information, a really, really good resource. So if you've never visited their website before, then I would encourage you to do that, because there are loads of tools that can support us in managing patients, you know, with pressure ulcers and leg ulcers and surgical wounds. And actually, the last time I went on, I found the new recommendations really quickly. So it's not like you've got to delve deeper and deeper into the website. You know, they're available really easily for people to be able to access. But, you know, I also don't want to be a scaremonger as well around this new categorisation, because, you know, different organisations will slowly implement, I would imagine, the new recommendations, because you have to have all of the internal systems and processes in place to support the changes that are being recommended. So like, you know, Purpose T being the recommended pressure ulcer risk assessment tool, for example, you know, that isn't the risk assessment tool that is used currently in all organisations. And perhaps, you know, there's a feeling that organisations want to change to that because it's what's being recommended. But that can often be a slow process and a huge learning curve, I think, for some organisations. So, yeah, don't want to frighten anybody, but you just keep your eyes out. And I would encourage you, as Charlie said, to go onto the National Wound Care Strategy Programme website to get some more information about what is being currently recommended. And then ask questions within your own organisation. What is it that we're doing about this? Because the leaders in healthcare within your organisation will be aware of these recommendations and hopefully have plans in place as to how they choose to use this information to support you know, patients who are at risk of and have developed pressure ulcers within your organisations. Any other comments, or shall I move on to the next session? I'll move on because I think I've talked too much already, haven't I, Charlie? It's always the way.
Not at all, Ellen, not at all. There is just one comment to say a big thank you to you for how clearly that you have explained the topic, especially the patient safety incident reporting framework. So there are a couple of comments saying thank you for that.
Oh, you're very welcome. Glad it was useful. Right, I'll share my screen again. Give us a shout out, my colleagues, if you can't see my screen, but I think you probably can. So
yeah,
now
it's
all good, fantastic. So now I'm just going to do a relatively short session around simplifying wound healing, and this is something that we are very passionate about in Coloplast. We want to make life easier. We want to make life easier for our patients, and we want to make life easier for the clinicians that are helping these patients with often very challenging wounds. So we have thought, you know, for a long time about what can we do to help make life easier? How can we simplify the wound healing process? So I'd like to talk to you about what we call the two-step approach. Sorry, it's not 2 steps at all, completely lying. It's a 3-step approach, with the first step of the 3-step approach being assessment. So we all know that we do a holistic assessment of our patients. We do a holistic assessment of all patients that have nursing needs, but with wounds, We do an overarching holistic assessment of our patients, and then we focus in around what challenges that might be happening for that particular patient in terms of their wounds. We need to be able to identify healing objectives for that particular patient, because if we don't understand what potential barriers there are to healing, then we are unlikely to make good decisions about how to move that patient forward on their trajectory towards healing. So we identify our barriers to healing and come up with objectives as part of our holistic assessment of that patient. And then step 2, we need to pay really careful attention in how we prepare our wounds. And I would suggest that this is probably a step that is often overlooked altogether or played lip service to. We don't pay careful attention to wound preparation, but the emerging evidence, and there is existing evidence, lots of existing evidence to suggest that actually wound preparation is a fundamental aspect of the management plan for that patient's wound healing journey. It's not something that we can pay lip service to. It's not a step that we can skip. We need to pay really careful attention into how we prepare our wounds to help remove some of those barriers to healing that we identified during our wound assessment. And then we move on to step 3, which is how we treat our wounds. And there is a huge portfolio of dressings from Coloplast that can help simplify step 3 of the wound healing journey for that patient. So we've done our assessment, we've identified healing objectives, we've identified what barriers to healing might be pertinent for that particular patient. We then need to pay careful attention to the preparation of that patient's wounds for healing. And then we need to have access to simple dressings, simple treatments for that patient, which are going to help that patient along their healing journey, as I've said. So we look into those in a little bit more detail. So we have a very simple wound assessment framework called the Triangle of Wound Assessment. So the Triangle of Wound Assessment is around doing a holistic assessment of the patient, where we look at the patient's comorbidities, whether that patient, as an example, might be diabetic, might be anemic. We look at their lifestyle choices. We look at their medications. We look at lots of different aspects within that holistic assessment of the patient, which could potentially cause that patient a problem in their wound healing journey. And then we look more closely at the wound itself, and we split the wound into 3 different areas. We look at the wound bed, we look at the wound edge, and we look at the peri-wound skin. Within the wound bed itself, we identify any tissue types that we can see, any devitalized tissue that might be there, slough, necrosis. We might see some old remnants of dressings from the previous dressing change. We need to take all of that into account as part of our wound bed assessments. We look at the level of exudate, not recording it as plus or plus plus or plus plus plus. We need to have a bit more objectivity to that. So is it dry wound? Is there no exudate? Is it low exuding? Is it medium? Are there copious amounts or high levels of exudate? And we also look at the colour and viscosity of that exudate, because exudate can tell you a huge amount about how that wound is progressing. We also look at signs and symptoms of infection. Is this wound having a problem with a bacterial burden that we need to pay careful attention to in our preparation and in our treatments that we choose for that particular patient? At the wound edge, there are often common challenges that you might see, such as maceration. You might have a dry wound edge. There might be some undermining present. We need to know about all of these challenges to be able to address these challenges in the treatment that we choose for a patient. Wounds, at the end of the day, healing by secondary attention, they heal from the edge. Those epithelial cells, at the end of that proliferation period, will migrate across the surface of that wound to finally close that wound. So if we don't have a healthy wound edge, we're going to have a problem with this patient. We then look at the peri-wound skin. So, the condition of a patient's surrounding skin or peri-wound skin can absolutely tell you a lot about the health of that wound. And these are, again, some of the common challenges that you might see as part of that peri-wound skin assessment. If the maceration isn't dealt with, when it's, a problem at the wound edge, it can extend and cause problems on the surrounding skin or peri-wound skin. We might see excoriation. We might have skin that's very dry, that can crack and potentially cause a problem, again, with cellulitis, maybe, because it's a portal of entry for bacteria. We need to take all of these things into account and incorporate them into our management plan for that patient. Let's move on to step 2. I've talked, you know, a little bit about how fundamental preparation of a wound is in that patient's journey. And there are many different tools available in terms of wound preparation, in terms of debridement and wound cleansing. However, there is a really simple tool that you could have access to called All Prep Pad. An All Prep Pad is a mechanical debridement tool which simplifies the process of mechanical debridement to help support removing those barriers to healing and support optimal wound healing environment for that wound as you move on to step 3 or the treatment of that wound. The tool is 2 tools in one. So it would be used with the dark grey side, as you can see in the image here, to loosen as it's massaged across the wound bed, across the wound edge and across the peri-wound or surrounding skin, to loosen all of that devitalized tissue, to provide disruption for the protection that biofilms that can have in the wound bed itself and deeper in those wound tissues. So biofilms we need to consider are now a problem for between 80 and 100% of wounds that are difficult to heal, and they are protected within those difficult to heal wounds. We need to cause those biofilms a problem. We need to disrupt their protection, and All Prep Pad is a fantastic tool at being able to cause that disruption. So after we've done that loosening and massage that dark grey side over the surface of that wound, the wound edge and the peri-wound skin, we can then use the lighter grey side to help absorb all of those tissues, all of those cells, all of that debris that we've loosened with the dark grey side. And it's also really easy and convenient to use, and it's made ergonomically designed to help it easy for you to hold and do that massaging effect on the wounds that you choose to use mechanical debridement with. And it's so simple and easy to use, and I would encourage you to have a look up about All Prep Pad and find more information you know, on our website about All Prep Pad and how you can prepare wounds really effectively using a really simple tool. And then we move on to step 3, and we are going to get the best out of step 3 if we look at step 2. So you will get the best out of the treatment that you select for a patient if you prepare your wound really, really well. And there are a portfolio, again, of simple dressings that are easy to use, which can support, you know, that patient's progression towards healing. So we talk about biotain silicone with 3D Fit technology, and 3D Fit technology is absolutely unique on the market in terms of other foams or more traditional foams that are available, and it works very, very differently to all of the other foams that are available. And the way it works differently is that it absorbs the exudate vertically into the dressing itself, and because it has that vertical absorption, it helps to protect the surrounding skin and that really important wound edge from any maceration. So there is no possible way that exudate that's absorbed into the dressing can spread laterally across the pad of that dressing. It is held in that dressing vertically and protects that surrounding skin and that wound edge, which, as I've said, is really, really important. And as it absorbs that exudate vertically into the dressing, it will conform down into the wound bed. Any opportunity that exudate has to pool within a wound bed, and don't, you know, be fooled, even a wound that looks, you know, fairly superficial as you look at it with the naked eye, which you wouldn't say has any depth to it at all, there is opportunity within even those superficial wounds for exudate to pool, for that bacteria that's within that exudate to proliferate and start to cause a problem. So 3D Fit technology helps to negate that problem because it will conform down into that wound bed to fill in all those little nooks and crannies up to 2 centimeters in depth. So any wounds previously where you might have thought that you would need to put a filler into that wound to help manage that gap, to help absorb that exudate that could pool, you don't need to use that with 3D Fit technology, with biotin silicone, and that's because it is so simple to use and it will fill that gap for you to help negate that problem. And the third way it works is that it will retain that exudate within inside that dressing and 99.98% of bacteria to help reduce the risk of infection and to help protect, again, damage to that peri-wound skin. Once we've absorbed that exudate vertically, we've conformed to the wound bed. We don't want any opportunity for that exudate to leak onto that surrounding skin or to get back into that wound to cause us a problem. So that's really, really important. I'd like to talk to you about a couple of case studies very quickly. So this is a case study around a young male patient. I mean, I say young, he's young to me, I'm now 45. He's 39 years old, and he had a long-term pressure ulcer present, 15 years, on his ischial tuberosity. He also suffers with spina bifida and walks on crutches. A very independent chap with a very busy work and social life. Wasn't really taking any medication to speak of. So upon his assessment, it was identified that the wound needed to be really well prepared and to remove all of that non-viable tissue. We also identified that we needed to manage the exudate more effectively to help prevent that maceration from building up again, to manage that bacterial burden, and to protect any surrounding skin. So in terms of Jamie's preparation, all prep pad was used, and you can see the difference here. After all prep pads was used, that there was a huge reduction in the amount of devitalized tissue within that wound bed and at that wound edge, which absolutely helped with his journey towards healing. And then in terms of his treatment, he was initially treated with biotin alginate AG because the wound was deeper than 2 centimeters initially. And then it was used biotin silicon with 3D Fit technology as a secondary dressing for that conformability and for that vertical absorption of exudate. You can see how well here that this pressure also responded initially to all prep pad, and responded in terms of its bacterial burden to the biotin silicon, to the biotin alginate AG, and the wound progressed really well. Patient was experiencing much less in terms of leakage and maceration, and had much better control of the exudate and bacterial load because there was that continual wound preparation and that disruption of those biofilms that were causing him a problem. And then finally, we talk about Mr. D, who was a 55-year-old chap. He was diabetic, and he had his big toe on his left foot amputated in secondary to his diabetes. He also had some level of arterial insufficiency, which we know is common in diabetes. He was having lots of dressing changes a day, and they were struggling really to manage the exudate levels with this chap. So in terms of assessment, the objectives were identified as being to remove that non-viable tissue, again, to manage the exudate, manage the bacterial burden, and help protect that newly formed granulation and epithelial tissue, and the wound edge and the peri-wound skin. Again, all prep pad was used. And you can see within these pictures here, from day 1 to week 14, the absolute significant difference for this chap in terms of his healing trajectory. It might seem to you that 14 weeks is a long period of time. However, with this patient's arterial insufficiency and his other comorbidities and the bacterial burden, it was a significant improvement and a huge improvement and a fantastic outcome for this particular patient who was managed with all prep pad. Initially with biotin silicon AG to manage the bacteria, and then subsequently to that, they were able to stop the AG dressing and move to biotin silicon with 3D Fit technology to help manage his exudate and move him forward towards healing. So that's the end of my session. Have we got any comments? Anybody? I'll stop sharing. Charlie, Sam?
Hi, that was a brilliant session. Thank you.
I've only gone 5 minutes over. I think I can be forgiven.
Well done. A couple of comments about how good all prep pad has been for some of the people that have been using it. Somebody asking whether all prep pad can be used in paediatrics, and it is not contraindicated to use in paediatrics. So it will be about your assessment of that patient and whether it's appropriate to use it for that patient. A couple of people sadly had to leave, but are looking forward to the recording that will be sent at the end of this.
That's fantastic. Thank you. So I'm going to hand over to my beautiful colleague Charlie, who is going to finish off this morning session with our Coroners Court. So take your seats, make yourself comfortable, and I hope you enjoy the rest of the session. I and Sam will be keeping an eye on the chat, and we'll have a discussion after each video to hear your thoughts and to have a bit of a chin wag between each other about what we thought happened during the video. Over to you.
Right. Everybody see that? Yep. Okay. So this is the bit you've all been waiting for. So we're going to go through the Coroner's Court, and what will happen is we will play a short video, and then we're going to have a discussion in between each. Please feel free to put any comments in the chat if you have got any questions, or if you just want to make a comment on what you've seen, then that's absolutely fine. So you as the audience are going to play the role of that expert witness and the coroner to deliver your findings. And as you can see, there are 5 short videos, and we'll have a discussion in between each of them. So without further delay, we'll get started.
I am resuming the inquest into the death of Elizabeth Black that was initially opened on the 3rd of April 2022. It is my duty today to listen to the evidence requested in order to assist me in answering 4 questions. Who the deceased is, when, where and how they came by their death. Who, when and where are usually straightforward. It is how they came by their death I need help with. I can confirm that the deceased's full name is Elizabeth Mary Black, but her family have expressed a wish for her to be referred to as Betty throughout this inquest. She was born on the 1st of January 1934 and died on the 31st of March 2022 whilst a resident in Boot Hill Residential Home. In order for me to be able to issue a death certificate, I need to establish the circumstances surrounding the death of Betty. I will gather the evidence, and based upon that, I will issue a death certificate. Under Rule 42, no verdict shall be framed in such a way as to appear to determine any question of criminal liability or civil liability. Based on the witness statements I have to date, I have taken the decision not to call a jury in this case. I may have to reverse that decision should evidence come to light which would suggest a jury is required. In order to help me today, I have called several witnesses to court and have legal representation for the hospital, for the residential home, and a brief statement from the family. It may be that I cannot actually conclude death due to natural causes, depending on contributing factors and the evidence heard during this inquest, in which case I will form a narrative version. We have heard from the pathologist, who has identified the cause of death as 1A, sepsis, secondary to 1B, infected sacral pressure ulcer with signs of osteomyelitis in the coccyx, to a heart failure. Following a fall, Betty was taken to the hospital and was assessed in the accident and emergency department, where she was found to have sustained a fractured femur. Could Miss Brown come to stand? Please, can you confirm your name and your current employment?
My name is Miss Brown, and I am the Deputy Director of Nursing, representing the A&E and orthopaedic wards.
When was Betty admitted, and what was she like?
Betty was first seen at the A&E department at 7:30 a.m. following a fall at her residential home during the night.
Was Betty triaged?
No, she had been brought in by ambulance.
Someone must have triaged or received a handover of Betty. How did the ambulance team hand over?
She was handed over to one of the night staff who triaged her. She was then put in reception on a trolley and was assessed by an A&E nurse at 9 a.m.
Why did she wait so long to see a doctor?
The department was very busy. The A&E nurses had numerous ward transfers, analgesia to administer, and overdue observations for patients.
And what happened then?
She was heard to ask for help and was seen by a doctor who sent her for an X-ray, which showed she had a fractured hip.
And how long was she in X-ray?
Approximately 50 minutes, ma'am.
And how long was it in total before she went to the ward?
She waited 8 hours to be admitted to the orthopaedic ward.
Why did it take so long to admit Betty?
There had been an outbreak of norovirus, so Some of the wards were closed and the remaining wards were full.
So Betty spent 8 hours in A&E. What was Betty laying on during that time?
An A&E trolley.
Was Betty given any pressure ulcer prevention during that time?
I'm not sure.
Why are you not sure?
I cannot find any records to confirm. I'm sure we tried to turn her, but she was in pain.
Was Betty offered any pain relief?
I will need to consult the notes. Nothing is documented here to say that she had any pain relief.
Can I confirm what you said? Betty was on a trolley without any pain relief for 8 hours.
According to the notes, yes.
Did anyone ring the family?
No. It was assumed that the residential home would have contacted them.
Do you not think it was important to ring the family?
Yes, but I can understand why, as the department was very busy that morning.
Please can I ask whether Mr. Park, the solicitor representing the hospital, would like to ask any questions?
Yes, thank you. Ms. Brown, is it correct that you were particularly busy that morning as you'd had 2 major road traffic accidents in the night before?
Yes, that's correct. Apart from the normal high volume of patients arriving at A&D, the department was still very busy due to the RTAs, which resulted in serious injuries and one death.
Okay, and since this has occurred, you've put extra procedures in place to help prevent this situation from happening again.
Yes, we now have charts on the wall for each patient detailing their specific needs, especially for pressure ulcer prevention. Also, the trolleys and mattresses have been changed to assist with pressure relief, and we now routinely turn all patients.
No more questions.
Thank you. Can I ask if Mr. Smith, representing the residential home, would like to address the witness?
Ms. Brown, were you aware that the residential home rang the family?
No, I wasn't aware. I just assumed they would, as it was one of their residents.
Were you aware the residential home sent a letter about Betty's medication?
Yes, it was in the notes.
Did you send a discharge letter back with her to the home?
Yes, as I said, all patients are sent home with discharge letters and copies posted to their...
Were you aware that when Betty came out, there was no discharge letter?
I wasn't aware.
This is not relevant at this time.
I agree.
Okay. So what did you think of the first video? What are we seeing so far? Sam and Ellen, is there any questions in the chat? I can't see the chat function, so. Hello?
Hello. So can you hear me?
Yes, I can.
Yeah. No, there's nothing in the chat. There's just a bit of an issue around the video playing at the moment, but people can hear, which is perfect. It's just a bit glitchy. So someone's put in that there were too many shortfalls. Seems like a lot of information was missing. So referring back to Ellen's session before, obviously it's sort of highlighting if you didn't write it, it didn't happen, because there's no sort of documentation to evidence the care they're giving. Poor documentation, no incident report completed. So yeah, quite a lot of good comments here. Lots of assumptions within what was happening, poor communication. Yeah.
Excellent. So with regards to some of the discussion points, you might be wondering why the solicitors were asking those questions. So in particular about asking the nurse why the A&E department was so busy and the fact that they'd had road traffic accidents in that evening. And this is to try and negate the fact that the department was extremely busy and therefore priorities were made. However, they also discuss about the now being charts on the wall for pressure ulcers and a repositioning routine. And does anybody know why the solicitor would be mentioning this at that time? Sam, Ellen?
Sorry, Charlie, I was trying to, for some reason I couldn't turn my camera on or my sound, or my sound on. Yeah, absolutely. The solicitor is, if we think back to, Regulation 28, the solicitor was trying to sort of make the point that they have already put measures in place to help preventing this kind of event in the future. No organisation generally wants a Regulation 28 imposed upon them because it doesn't look very good, in the public domain, in the media. That's probably the reason why he was sort of making those points to try and say, listen, we've recognised that this wasn't good, but we've put those measures in place to try and mitigate that from happening in the future.
Absolutely, because ultimately no trust really wants to have a Regulation 28 on their trust. As you say, it's out in the public domain, and it highlights really the fact that somebody has died within that setting, and that death was avoidable. So absolutely, I think that's why the hospital solicitor was doing that. The residential solicitor, as we can see, has already asked about the discharge letter. And the reason being for the questions from the residential solicitor is to try and cast doubt over the hospital and what it is that they have or haven't done this far. So would you say that the communication has been effective so far between the residential home, between the hospital and between the teams within the hospital?
I would say we can already start to see where there are missing bits of documentation just from the evidence that was she the Deputy Director of Nursing there to represent ED and the trauma and orthopaedics wards. We can already see that she doesn't have all of the information to hand that she needs to provide the evidence that she needs to give, and it's clearly because it wasn't there. The documentation didn't support the care that was given or not given. So we're already starting to see that there are potential issues, aren't we, with what's happened for Betty, unfortunately.
And if the department was short-staffed, extremely busy, what should have been done?
Well, there should have been some form of escalation of that. I mean, we fall into the trap, don't we? We've just been on our hamster wheel all of the time, going into work, and we're really busy, and we're just trying to get on with our day and get through our shift and see all of the patients that needs to be seen, and perhaps doing more than is potentially safe, for the care that we are delivering. Perhaps I would say, and it's documentation that tends to go awry. Unfortunately, in this case, you've done that patient's dressing, or you've done that patient's observations, or you've changed that patient's continence pad or whatever, and then it's just not all documented in the records because you're then going on to see your next patient. So unfortunately, that's it sadly is the case. It's often the documentation that is the first thing to suffer, and it shouldn't be the case, should it? It's not fair on patients, and it's not fair on clinicians.
Absolutely. And as Ellen has already said in the documentation piece earlier, the documentation is what we really rely on, especially if you are called to a coroner's court. It's, as we've said, it could be months, it could even be years since you looked after that patient. And trying to recall sometimes what you did yesterday is difficult. So what you did months or years ago is going to be even more difficult if you haven't got your documentation there to back that up. Okay, Sam, have you got anything to add?
No, it's just carrying on. There's some good comments in the chat. They're just sort of, again, incident form wasn't completed, escalation. So potentially you can maybe, if senior management are aware, they can pull staff from other wards or other clinical areas to support. Lack of documentation, lack of communication, and also just highlighting that nobody contacted the family. So there's that assumption, isn't there, between everyone that everyone's assumed someone else has done it. So again, it's just that highlighting that communication where it hasn't happened.
And with regards to who should have contacted the family, should it have been the nursing home? Should it have been the A&E department? Should it have been one of the wards?
I think from my perspective, Charlie, the issue is, sorry, I interrupted you then, Sam. I think the issue is that it doesn't really matter who does it. The fact is that nobody knew whose job it was. So it's that failure to recognise what the process or system is, you know, within when a patient gets admitted from a residential home to the hospital, you know, whose responsibility is it? And like I said, it doesn't matter whose responsibility it is. The fact is nobody did it because everybody thought it was somebody else's job to do it. And I think that is another running theme through this case as we move forward through the videos.
Brilliant. Right, we'll move on to the second video.
Charlie,
Yes.
I've just I wonder if I share my screen rather than you sharing yours, just in case it helps improve the quality of the video. Is that okay?
Yeah, absolutely.
We'll have a go anyway. It might not work, but it's worth a try. Make sure I remember to share with sound. Okay, and we're on part 2, aren't we?
Yeah.
I'd now like to look at what happened when Betty was transferred to the orthopaedic ward. When was Betty admitted?
3:30 p.m.,
And when did she go to theatre?
5 p.m.
What did they do at theatre?
They repaired her fractured hip.
And were there any complications?
No, she came back to the ward and was quite well in herself.
Clearly there are no complaints about theatre. She had uncomplicated surgery and came back to the ward.
That's correct.
Any pressure ulcers when she came back to the ward? When did you start mobilising her?
Betty suffered with slight dementia, so the bed rails were up.
That's not the question I asked you. I asked, when did you start mobilising?
She was not mobilised until 4 days post-op.
Why not?
A physio assessment was required before she could be mobilised safely. However, the on-call physio team was running on skeleton staff and had several chest physio patients to deal with.
Did you get her out of bed at all?
No.
Did you do any pressure ulcer risk assessment before she went to theatre?
No,
Why not?
it wasn't time. By the time she arrived on the ward, she was prepped straight away for theatre.
Was there any assessment after surgery?
I will need to check the notes. No, it would appear not.
Why not?
I'm not sure. We must have forgotten.
Did you put her on any special mattress that might have helped prevent pressure ulcers from developing?
No.
Did you turn her?
Yes. When we washed Betty in the morning and changed her sheets, but not regularly until the Sunday, when we realised she wouldn't have a physio assessment until Tuesday.
Why not?
Each shift, we were expecting her to be assessed to be mobilised. So we didn't implement a turning regime.
Did you or your team undertake a risk assessment on Betty at any time?
No, not until the pressure ulcer developed on day 4.
When was the pressure ulcer first noted?
We noticed that her bottom became red on the 4th day.
How did you treat the patient?
We applied a dressing to it as it was weeping onto her nightie and bedclothes.
Was it working?
Yes, the dressing appears to have managed the exudate and was changed every 2 days.
Did it deteriorate?
Yes, it did.
Did you reassess Betty?
She would have been reassessed at each dressing change.
When was she sent back to the care home?
She was sent back to the home on the 12th of March.
I have no further questions at this time. Mr. Park, do you wish to ask any further questions?
Yes, thank you. Let me summarize. Your department were extremely busy and short-staffed because of the norovirus. Betty went to theatre and experienced no complications. She didn't fall out of bed because the bed rails were up. And the family seemed very satisfied by their mother's care.
Yes. At no point was any complaint made regarding her care whilst on the ward.
No more questions at this time.
Thank you. Mr. Smith, do you have any further questions?
I have no particular questions about her treatment, but was a discharge letter sent back with her to the home?
Yes, as I said, all patients are sent home with a discharge letter and copies posted to their GP.
So the care home did receive a discharge letter.
I would need to check the notes. It would appear that the letter was left behind and not given to Betty to take home. It is documented the discharge letter would be given to the ward clerk to put in the post.
Point out the discharge letter didn't arrive until 3 weeks later.
I don't know what happened with that.
Whilst I appreciate you were short of staff, the care home were also short of staff. Let me point out how residents don't get pressure ulcers.
This is not relevant at this time.
I agree.
It is quite clear she had a Category 4 pressure ulcer when she left the hospital and returned to the care home, where there was no discharge letter to advise the home of her current condition. Did you ask the district nurses to call?
An answer phone message was left for the district nurses to call at the residential home the next day.
What time was this done?
Approximately 4 p.m. on the day of discharge.
Did you send a letter to the district nurses telling them of her condition?
No. Usually the discharge letter would be passed on to them.
Did you ask the community tissue viability nurse to call?
No, I thought the district nurses would refer to tissue viability once they had assessed her.
No more questions at this time.
We now have a discharge process for all to follow.
Thank you, Mr. Park. Please don't interrupt. You'll have time to offer information prior to summing up on the case.
Okay. So I can see that the chat is very busy, with lots and lots of comments and lots of people saying about lapses in care, and whether we were acting in the best interests of Betty or not, and lots of assumptions being made about whether things had or hadn't been done. So Sam, Ellen, how effective do you think the handover was from A&E to the ward nurses?
So in terms of,
sorry, no, go on, Sam.
sorry, I'm a bit on a delay, I think. So it wasn't as effective as it could have been. They obviously omitted quite a few assessments, and things weren't communicated well between the different teams. Obviously, she didn't have that risk assessment before she went into theatre, and that again is just not highlighting that vulnerability of someone going down. I think, you know, this is a made up scenario, but you can sort of see how in practice it could happen. So yeah, I don't think it's very evident, and lots of the chat in the boxes around that communication was sort of lacking, and could have been a lot more effective.
Absolutely. Ellen, did you have anything to add?
Yeah, I absolutely agree. But I mean, for me, as we'll see, that pressure ulcer risk assessment completion was significantly delayed for Betty. But, you know, at the end of the day, you know, do you need a risk assessment tool to give you a number which tells you if, you know, if somebody's at risk of a pressure ulcer or not? You know, if you get somebody who's got a fractured neck femur, who is elderly, who's come from a care home, and they're going straight down to theatre, it doesn't, you know, it's not rocket science to use your clinical judgment and say that like this patient is going to be at risk of a pressure ulcer. So, but as we'll say, you know, there is significant delay in doing that risk assessment. So, in terms of, you mentioned people, because I can't see the chat now, sorry, because I'm sharing my screen, mentioning about care lapses, absolutely, there was a failure to make good clinical judgments around Betty, and, you know, and preventing her from developing a pressure ulcer. There was poor communication in handover from, you know, ED to the wards and then to theatres. You know, and more failures in communication, as we'll see in the next videos.
Absolutely. I think there was definitely some difficulty in the staff that were actually looking at the area that they first described as red, but never mentioned that it was broken until they said they put a dressing on, and because it was leaking. So it can't have been red and unbroken skin. So there's clearly some difficulties here in categorizing what it is that they can see. And that's why it's really important with your documentation. If you are unsure of what category of pressure ulcer it is you're looking at, write exactly what it is that you can see. Is there any depth to it? What's the tissue type? Whereabouts is it? Write exactly what you can see, and quite often from that, a specialist can come along and help you make that determination in the categorization of that pressure ulcer. It's not always straightforward, and if it's not something that you're doing on a daily basis, can be quite difficult, but just make sure you're documenting exactly what it is that you're seeing.
And photography as well can really help,
Yeah.
can't it? In helping with that category, that assessment and that initial sort of triage, I suppose, about what is it that we're dealing with here. You don't know what category it is. A picture can tell 1,000 words sometimes, can't it?
Yeah, absolutely. So again, our solicitors, our hospital solicitors, trying to paint the hospital in a really good light. Obviously, that's what they're there to do, is to defend their clients. So he was saying about how the surgery went well, that Betty hadn't fallen out of her bed, but then obviously the residential solicitor again had sort of arguments against what the hospital solicitor had already said. And again, we're talking about and that discharge letter. That's a key focus for the residential home, is this discharge letter that apparently wasn't actually sent. Okay. So shall we, any other comments, or are we happy to move on to the next video?
There's just some more comments just saying about the discharge summary. Some people are obviously finding that actually out in practice, that sometimes there is that delay in them coming into the healthcare setting. Also, just about that delay and with the physio assessment and not getting Betty out of bed. So again, there are lots and lots of issues within this. But yeah, great comments. Thank you, everyone.
Shall I move on, Charlie?
Yes,
Yeah.
please.
Can Mr. White come to the stand? Can you confirm your name and your current employment?
I'm Mr. White, and I'm the manager of the residential home.
You are one of the senior nurses?
No, I'm the manager, but not a registered nurse.
How long have you worked there?
For approximately 10 years.
You know your residents well?
Oh, yes. I work predominantly days, so I get to spend a great deal of time with all my residents.
Now, can I first of all ask you to run through Betty's situation?
Yes, Betty was found on the floor during the night between the commode and the bed.
Did Betty have bed rails up?
No, Betty was quite independent with her frame and could get out of bed herself. She had been doing this for the past 5 years. Her family knew that she could quite safely potter around the home and would have her buzzer if she wanted us.
And is it correct that she was found at 6:15 a.m. in the morning?
Yes. One of the carers found her whilst doing his hourly rounds.
When was she last seen?
According to the carer, he went round at 4 a.m. and looked in on Betty, who was fast asleep in bed.
Did Betty normally go to the toilet during the night?
Yes. She had her buzzer, but would normally use her commode herself and would only ring the buzzer if she wanted a cup of tea.
Had she rung the buzzer that particular evening?
No, on this particular evening, she had slept very well.
And did you hear any noise at all?
No, nothing. The carer just popped his head in that morning to check on her, as he would normally do.
And what did he find?
He found Betty on the floor between the commode and the bed. She didn't have a Zimmer frame with her this time.
Was Betty able to tell you what had happened?
Not really. She was, well, how shall I say? She was a happy but confused lady. She said she'd fallen, but the carer said she'd wet herself, so we assumed that she'd fallen trying to get to her commode.
And what did the carer do?
He pressed the emergency buzzer and called the senior carer on duty, who decided to call an ambulance as Betty's leg appeared to be shortened. She also appeared to be in a lot of pain, so the carers didn't want to move her.
And Betty was taken to hospital.
Yes, the paramedics arrived, gave her some pain relief, and took her to hospital.
And how long did it take?
They came within 20 minutes. Paramedic arrived initially, followed by a 2-man ambulance crew. They made her as comfortable as possible and then took Betty to hospital.
So, how long was Betty on the floor for? We're not really sure, are we? Because the gentleman from the residential home, sorry, said that they do hourly rounds at night time to check on their residents. But Betty was last checked at 4, and she was found on the floor at, was it 6:15? So
Yeah.
that's not an hourly round, is it? There should have been another round at 5, and then another one at 6 o'clock. So we're not entirely sure yet how long Betty's already been on the floor. It could be at least 2 hours, and that's if she was checked at 4 o'clock. So we're not sure how long Betty's been on the floor for. So we're not sure how long that damage has been sustained to her skin already. So where was Betty's commode positioned in relation to her bed? Because it's, you know, it's said that Betty has been able to get out of bed and take herself to the toilet for quite a long time. But has there been a reassessment of Betty's mobility through the night recently? Doesn't say how long ago that it would. I think, did it say that it was about 5 years ago that assessment was done? So how recently had her reassessment been done? Have you got any comments, Ellen and Sam?
I suppose my comment is, it was, you know, even irrespective of the fact that they said, you know, she was last checked at 4 and then they were found at 6:15. What does a check mean? What's the definition of an hourly check? Because that could be coming in to the room, you know, checking that she's okay, she's got her buzzer, where's the commode, where's the Zimmer frame, or a check could just be popping your head around the door and checking that she's asleep, doesn't it? So we don't have any information about what those checks were, really. Yeah, Sam, do you have anything to add? She's definitely on a lag, isn't she?
Yeah.
Yeah, and there's also a question about staffing levels, isn't there? Do we, you know, we don't know if there was sufficient staffing levels in the care home that particular evening. You know, what was the ratio between patients to staff, and what was the, you know, the assessment of the assessment of her when she was in the care home seems to be, to me, to be significantly different to how she was when she was in hospital. So in the hospital they were using bed rails, weren't they, to stop her falling out of bed, but they didn't feel like that was required within the hospital. So that is within the care home, sorry. So that is suggestive that there has been you know, a change in her mobility and her mental health, if you like. So she was, it would appear that she was more confused. Was that the case, or was it that they just didn't know her as well as the staff within the residential home? It's all a lot of unanswered questions, isn't it, really? But potentially all areas that could have you know, played a part into Betty ending up in the position that she was in.
There is, and there is an awful lot of unanswered questions, and I think as we watch the next couple of videos, I'm not entirely sure your questions will be answered. That there will be a lot of questions that you feel need answering and perhaps haven't been. So Sam, are you there with us, or
Yeah,
have we lost
sorry,
you?
I've had to leave my computer. I'm now on the phone. The weather's a bit rubbish in the south, I'm afraid. Got a bit of a storm over us. But yeah, there's some great chat. I'm keeping an eye on it all. Yeah, anything, I'm back in the room.
Brilliant, thank you. Excellent.
Would you like me to move on to the next video, Charlie, or?
Yes, please, Ellen.
Yeah, okay.
Now, I want to talk to you about when Betty came out of hospital. What was she like when she came back to the home?
She wasn't mobilizing, so we had to hoist her onto the bed. And she had a dressing on her bottom that was dirty and soiled in places.
Did you receive a discharge letter?
No, there was no discharge letter. I contacted the hospital ward to get information.
Was she sent home with any medication? Was there any information regarding this from the hospital?
No, nothing. After speaking to the hospital, we found out that she was on the same medication she was on prior to her admission. So we had everything here.
So Betty just arrived in an ambulance from the hospital?
Yes.
As you had no information, what did you do?
We rang the district nurses, who said it would be Wednesday or Thursday before somebody could visit to assess Betty, as they had no availability for extra visits.
Did you tell them how bad the ulcer was on Betty's bottom?
No, at this stage, all we knew was that she had a dressing on her bottom that needed assessing and changing. We are only a residential home, so we can't do those things.
How did you cope with Betty's needs?
With difficulty. We're not qualified nurses. We are a care home who rely on the local district nurses for nursing support. We didn't have all the relevant equipment ready for Betty when they sent her home.
What did you do?
Betty needed nursing care. So I rang the district nurses again. We couldn't wait. We didn't have any dressings available, and Betty's dressing really needed changing.
Did you speak with anyone?
I left an answer machine message. The district nurse did phone back the following day. But in the meantime, we put her back on her old medication and put on a dressing from another resident, as we had to make her clean and comfortable. We also gave her a good wash, as she looked dirty, and cut her fingernails, which had grown so long and were dirty underneath. What Betty liked best of all was a good cup of tea. She was so thrilled to see us, as we were faces that she knew. She was a lovely lady, and we loved talking to her. A bit confused at times, but we loved having her around.
What happened with Betty over the next few days?
The district nurse called to see her and was appalled at the state she was in. She'd never seen anything like it and didn't know how the hospital could send her out like that. We are only a care home, but we were just left to cope. The GP also called after 2 days and prescribed some antibiotics. The district nurse changed the dressing, but poor Betty was so poorly she just went downhill.
What do you mean she went downhill?
She seemed to lose the will to live, stopped eating, would still drink, but she lost her spark. Betty's wounds started to smell, which upset her, and she wasn't able to get in and out of bed herself, and would ring the bell if she needed the toilet, but would sometimes soil herself before we got there. It was painful for Betty to move and sit up in bed due to the pressure ulcer, and then she developed a chesty cough, so we rang the GP. She begged us and the GP not to send her back to that hospital. And John, her son, asked if we would keep her at the home and care for her there. Although we're only a care home, we couldn't send her back to that hospital. Sadly, Betty died a few days later. We cared for her and were with her when she passed on. She seemed to be at peace.
I have no further questions at this time. Can I ask Mr. Park, representing the hospital, if he has any questions?
So it's a really sad situation, isn't it? And probably one that happens more than we'd like to accept, to be quite honest. So with regards to what we've just seen, what was the impact of those missed visits by the district nursing service and the residential home? It meant, didn't it, that Betty's care was delayed? It was a residential home that she went back to, not a nursing home, so they don't have nurses there, and they rely heavily on the district nursing service to support them with dressings, with assessments of patients, and sadly, because the district nursing service didn't pick up those messages and didn't come to see Betty in time, that meant that her care was delayed. And I've seen quite a lot in the chat about how the DNs should have been contacted by the hospital. Absolutely, they should have been. The discharge, whether you've got a discharge team or whether you have to do your own referrals from the wards or wherever it is that you're working in that hospital, absolutely there should have been a discharge referral done to the community nursing team, and probably one that was quite urgent for that team to go out and assess that patient or Betty quite quickly. So what do you think, Sam and Ellen, the impact of that relationship between the district nurses and the care home would have been?
I think for me, sorry, Sam, go on.
I was going to say, I think for me, it's that relationship between the district nurses, but before even Betty was discharged, and there's been a few comments again in the chat, it's about making sure that she was getting discharged to the most appropriate setting. And as it was a residential home, they should have had some sort of review and check in the hospital prior to discharge. And like I say, there's been lots of comments about that, about whether she was appropriate to go back to that residential home. In terms of that relationship with the district nurses, it's that escalation again, isn't it? And it's having that relationship that you can call upon those specialists that you need when you need them, and that they come in a timely manner.
I would completely agree, Sam. And I think, you know, again, we're just seeing lapses in communication. It screams to me that the person who was decided that Betty was okay to go home was probably, she was on an orthopaedic ward, it was probably the orthopaedic surgeon who said, yeah, from a repair of a fractured neck of femur, she's fine to go home. So it's the ward nurse's responsibility to then facilitate that discharge. You know, I might be, being a bit generalist, but, it was like a Friday afternoon. She just needed to get this patient out because they needed the bed. And perhaps, what did the ward nurse who was responsible for sending that patient home know that there was a discharge coordinator who needed to be involved in that care? Was she aware? Does she have the level of knowledge and skill to recognise that actually potentially this is a really unsafe discharge for this patient? Because although she might be fit to go home from a surgical point of view, she has obviously deteriorated in her nursing needs because she's now got, a pressure ulcer. Her mobility isn't what it was. She's probably a bit more confused than she was before. So again, just lapses in communication all the way along her journey. And as you said, Charlie, it's a really sad story. And I also think in terms of the communication between the care home and the district nurses, they rang and said, an urgent visit. Well, how did they articulate that? What was the interpretation of, well, what's urgent? And I know certainly from speaking as a tissue viability nurse in the community, we used to have a referral form which would have a box where you would tick urgent or non-urgent. And more often than not, the nurse who's making the referral will tick the urgent box with no clinical rationale as to why that patient was urgent to be seen or not. It was, well, if we tick urgent, the TVN is going to come out a bit quicker. So again, communication. What does urgent mean? Do I really need to come? Urgently. Tell me why. But there was just that failure in the communication along the way for Betty, unfortunately.
Absolutely. And somebody has just put about collaboration in the chat, and there was no collaboration between any of the services that this poor lady needed. it was all very individualized. The hospital worked alone. The nursing, the residential home tried to involve other services, but there was no collaboration. And as you say, Ellen, no communication between these services. And communication when we're moving patients between services, whether it's from the acute community or wherever it is absolutely key to making sure that there's a patient at the end of everything that we're doing, and that's what we need to remember. And in this scenario, it feels a little bit like Betty was forgotten about, that she's actually a person, and not just a patient with a wound or with a fractured neck of femur. She's a person, and that seems to have been lost along this journey. So it's something that we all need to remember. We're all very busy within our own services, and we can all be guilty of blaming another service for care that hasn't gone quite right, but we're all responsible for our patients, and it's all our responsibility to ensure that the patient gets everything that they need to get at the right time. Right care, right time for that right patient is really important.
Yeah, I also think, and every time I see these videos, I have a different thought that comes to my mind, which makes the sessions take longer because I have much more to say every time I see them. But nobody has ever said during these sessions that I've done that it was okay for Betty to return to that residential home. Everybody recognises that she had nursing needs and she should have been placed in a care setting that was more appropriate to meet those needs. That didn't happen. She rocked up in an ambulance. They didn't know she was coming. There was no discharge letter, etc., etc. But there's also potentially a bit of emotional pressure on the care staff from perhaps Betty herself and from her family to accept her back. He said, didn't he? We always accept our patients back. We always take them back. And somebody without that sort of emotional attachment within that care home would potentially have just turned that ambulance right back around and sent Betty back into hospital. But they were worried about her. He made a comment about her nails being dirty and long. Well, she wasn't in hospital that long. So why was that point being made? It was as if he was trying to justify that she hadn't been cared for properly. She now had this massive wound. Her nails were dirty. Of course, we're going to take her back. We liked her. We enjoyed having her. Potentially not in her best interests at the point where she was being sent home. However, as we'll see, what potentially then did happen maybe was in her best interests, given at the stage of life that she was, after in the days after she got home. Like I say, every time I watch them, Charlie, I have more to say.
Yeah, I really enjoy seeing or listening to people's perspective, and because everyone sees things from a slightly different perspective, and listening to everyone's opinions. So it's really interesting to see. But just remember that we can all be very guilty of blaming the service before when that patient comes to us. And remember that we all, no matter where we're working, are all stretched, are all very busy, and we need to support one another. So it's really important that, yes, there might have been lapses in care, but instead of trying to just blame somebody else, we need to pick it up and we need to move forward to make sure that that's the right thing that we're doing for our patient.
Yeah,
okay.
I've talked too long and we've only got 5 minutes left and one more video to watch, so I'll click on to the next one.
Thank you.
Thank you, Mum. Betty had a fall at your home, did she not?
Yes, she had a fall, tried to get to her commode.
Did she not need nursing care to help her to the toilet?
No, for the last 5 years, she had been going to the toilet independently and would only use the commode at night, so she didn't have to walk too far soon after waking. All of our residents have quarterly risk assessments as standard, unless their needs change drastically in that time.
The nurse on the ward rang your home and you said you were prepared to accept Betty back.
But she didn't tell us that she had a huge pressure ulcer. She didn't tell us that she'd lost her mobility. She just said that she'd had her surgery, was fit for discharge, and asked if we were prepared to accept her back. We always take our residents back.
No more questions.
Mr. Smith, do you have any questions?
Yes, thank you. Can I just make it clear there was no discharge letter?
No, there wasn't.
Called the district nurses?
Yes, 2 or 3 times.
Called the GP?
Yes, with the district nurses when they visited due to their concerns.
Can you just explain to the learned coroner what type of patients you take?
We are a residential home, and all of our residents are assessed prior to coming in on their ability to perform normal activities. Most of our residents can mobilize with a frame or at least transfer themselves. We have 1 or 2 who require a hoist, but as long as they don't have nursing needs, we can accept them. If they do need nursing care, we work in partnership with the district nurses, and as long as they are happy and can support, we are also happy.
Do you have any qualified nurses?
No, sir, we do not.
No more questions.
Thank you, Mr. White. I now have a short statement to read from the family. John and the rest of the family would like to express their gratitude to all at Boot Hill Residential Home for all they did for his mother, Betty. They were very pleased you were able to keep her there and care for her, surrounded by people she knew and trusted in her last few weeks of life. Can I now ask Nurse Spears to come to the stand? Can you please confirm your name and current employment?
I'm Nurse Spears, a district nurse.
Have you been to Boot Hill Residential Home before?
Yes. We visit twice a week to provide a service for patients that require nursing care, such as catheter maintenance, insulin injections, change leg ulcer dressings.
Did you get notification from the hospital about Betty?
Yes. A message was left on our answer machine informing us that Betty had been discharged.
What information were you given?
Just that Betty had been discharged and that we would need to assess her.
Did the residential home ring you?
Yes, one of the carers left a message for us asking for urgent help.
Then why did you say you'd go in 2 to 3 days?
The care home didn't indicate why it was urgent on the phone, nor did we receive an urgent referral from them.
Did you get a second phone call?
Yes.
What did you find when you got to the home?
I was so shocked. I haven't seen anything like it for years. It was a huge sacral pressure ulcer. You could see the bone.
How would you grade it?
Category 4. We call them categories now.
Was the wound infected?
Yes. It was showing all the clinical signs of infection. We spoke to the GP who visited and said she needed antibiotics.
Think she was fit to come back to the residential home?
Not at all.
Why not?
Betty would have been fine to have been discharged with the appropriate discharge plan in place. That would have given everyone enough time to have provided the appropriate resources, such as mattresses, appropriate dressings, and support for the home so that Betty could be safely discharged back into their care.
Why did you not readmit her?
I cannot admit someone to hospital. I have to do that via the GP. The family and Betty didn't want her to go back into hospital, though. They were adamant. The residential home were happy to keep her with our support.
Did you arrange for some dressings?
Yes.
And who was going to change them?
One of our district nursing team was to call every day.
They call every day? Did you not hear my question?
Unfortunately, no. The district nurse did not call every day.
Why not?
Well, one weekend, I left a message on the handover phone for the weekend team to visit, but no one picked it up, so she didn't get a visit on that Saturday.
Did Betty's pressure ulcer start to heal?
No.
Why do you think it didn't get any better?
It was so bad when she came back to the home. Due to her reduced mobility, she had grown incontinent. Her skin was so delicate, and her general condition deteriorated very rapidly.
This is a residential home.
Yes.
Did you arrange for a pressure-relieving mattress?
We advised regular turning initially.
That was not the question I asked you.
It was on order.
Did it arrive?
Not before she died.
Who should have ordered this so that it would have been there in time?
If the hospital had given us enough notice, we could have had all of this in place ready for discharge.
Did you receive a discharge letter?
No, it actually arrived 2 weeks after Betty had died.
Was a referral made to anyone else?
No,
Why not?
I would have expected the hospital to have done that.
But surely, as a district nurse, wouldn't you request it?
Well, no. The hospital requests the district nursing team to visit. I would have requested them to have asked for the TVN referral if I had been aware of the situation.
Thank you. Mr. Park, do you have any questions for the witness?
Yes, thank you. When did you receive the hospital message about Betty's discharge?
As it was after 4 p.m, we didn't pick it up until the following morning. It didn't mention that Betty was ill or that she needed an urgent visit, just that she had been discharged from the ward and that we would need to make an assessment.
Do you see many pressure ulcers in the community?
We see a few pressure ulcers from time to time, but over the years that has greatly improved through education and training, especially in residential and nursing homes.
Thank you. No more questions.
Thank you. Mr. Smith, do you have any further questions?
Yes, thank you. Can I clarify that the residential home rang you and asked for an urgent visit and it was your decision not to do so?
Yes,
Can I also clarify that you called the GP and that he had already been called by the residential home?
yes,
Can I clarify that you did not receive the discharge letter, nor did the residential home?
yes, that's right.
Thank you. No more questions.
Thank you.
Okay, so you're now going to take on the role of the expert witness, and we need to have a little think about the following in the outcomes of this case. So, what Betty's admission to hospital was like, whether the care by the district nursing team and the care home following her discharge was appropriate, what the record keeping and the documentation was like, and whether the pressure ulcer was preventable. I think we could probably all agree that it is probably that the pressure ulcer was preventable. There didn't seem to be enough steps put in place to prevent this from occurring. And there certainly wasn't the documentation to support that these steps had been put in place. And whether or not the residential home, could have done any more to care for Betty. They obviously felt that they were able to care for her with the support of the district nursing service. But obviously lots of you have felt that she should have gone back to a nursing home as opposed to the residential home. So Sam, Ellen, have you got any thoughts on this video?
I think for me, what I'd like to clarify is whether a discharge letter was sent home with the patient, because it's not clear to me from the video so far.
No.
No, absolutely. And the Oscar for the actress playing the district nurse goes to Nurse Spears. You could see the bone. Fantastic. I absolutely love her. No, absolutely, and it's up to the people who are on the session this morning to now decide, isn't it, what they felt, what conclusion they felt that the coroner came up with in this particular case. So I know that we've got a poll to put in into the chat function, which I can't see. So hopefully that poll it's gone in now. So it's up to you guys. Hopefully you don't come up with suicides as one of the options, but it would be really interesting to see what you think the coroner thought in relation to Betty and how she came by her death. Like I say, Charlie, I can't see the chat, so you'll have to keep us up to date with the votes.
We'll do. So we've got about 70, 80 responses at the moment, most of which are for neglect. We've got 5 people voting for narrative at the moment, and we've got 2 people that have voted for accidental death or misadventure. But neglect seems to be the biggest one. We've got 94% suggesting that it's neglect, Ellen.
And that's really interesting for me, Charlie, because all of the sessions I've done, the biggest conclusion that people vote for is actually neglect. But I'll let you reveal what the actual outcome was in this case.
Okay, so it's 94% of you are saying neglect. Actually, the conclusion for this was a narrative. That was the conclusion that the coroner decided upon. It was a narrative conclusion. Neglect would suggest that there were no basic care needs for that patient, and there were basic needs for this patient, some of which may have been omitted, but not all of which. So it's a narrative finding for this case. Ellen, Sam, have you got anything to add? Have you had any other responses when you've done this session before?
No, I think it's most people do pick neglect, and it's like I said when I was doing the documentation piece earlier, Charlie. There was obviously a catalogue and a series of different things that happened to contribute towards Betty's death, unfortunately, and that's my feeling as to why the coroner came up with a narrative verdict in this case. Sam?
Yeah, so when I've done this session, neglect often comes up. But actually, I just wanted to say thank you to everyone for all their great comments. You've been really good at sort of interacting and bringing your thoughts into the sessions this morning. And, like Ellen said at the beginning, not everyone, it's highly unlikely you're going to be called into a coroner's court, but I think it's just a really good way just to highlight again that documentation, and this is a made up scenario, but it's a very sad story, but elements of it I'm sure everyone can sort of relate to within practice that they've seen. So that's from me.
So we've got one more question for you to answer as a poll before we finish up, and this is around the Regulation 28 and whether you feel that the coroner imposed that Regulation 28 in this instance upon those authorities that were involved in Betty's care. So if you can give us an answer, yes or no. So overwhelmingly the answer is yes at the moment. So the answer actually was no. For those of you that answered, thank you very much for joining in with that. Because the trust had already put in place their repositioning charts, they'd looked at their mattresses, they'd put everything in place before we'd got to the coroner's inquest. Therefore, they didn't need to have that Regulation 28 put in place. So they negated everything that could come up with that Regulation 28 before it happened. And absolutely, a trust does not want a Regulation 28 put in place upon their trust, their area, because it is open to the public, and it is an admission that a death has occurred that was avoidable, and nobody wants to have that. Nobody wants to cause a death of a patient, and so they've done everything that they can to make sure that this doesn't happen again. Sam, Ellen, have you got anything else to add to that?
No, I think absolutely everything you've just said. The coroner was obviously satisfied that enough evidence had been presented to negate the need to put a prevention of future death report in. I mean, we've not seen the whole inquest, have we? We've seen snapshots of the evidence that was presented for the purposes of today's session. But in this case, the coroner was satisfied that Reg 28 didn't need to be imposed upon any of the organisations for Betty.
So that brings us to a close for today. We do have a monthly webinar that we're going to be running, and it starts in December, and December's webinar is on leg ulcers, and we're going to look at how we simplify and make life easier using the Assess, Prepare, Treat that Ellen has talked about today. So if you want to join us, then please do sign up. Are we putting the link in the chat? The link's going to go in the chat for you if you'd like to join us for that. I'd like to apologise that we've run over a little bit, but this is it's a really emotive subject, and we often get lots of conversation around this. There is also an evaluation form that we would love for you to fill in if you can use the QR code, or there is a link that will also be posted in the chat. And there will be someone from our support specialist team that will contact you after this event just for your feedback, and they can answer any questions around the products that you've heard about today, or any services that are being developed to make lives easier for people that are living with wounds. So from Sam, Ellen and I, thank you so much for joining today. We hope you've got a lot out of it, and remember that your documentation is key. Thank you.
Thanks, everyone.